So just to kick off, hi, my name's Tom Witcher. I'm the CEO and one of the founding team of DrDoctor. So I've been here on our journey from a tiny 3-person scrappy startup to the 90 people we are today. And I'm here with Tom Gallagher, who's our data and insights manager, who's going to give the real meat of this presentation. He's the guy bringing in the smarts. I'm just doing the introduction, really. Just a kind of bit of background on us. So the fundamental challenge we're trying to solve here is that we think healthcare needs a reset. There is an ongoing supply and demand issue in care, and the COVID crisis has multiplied that by 10 times. You know, it's being manifested at the moment by the size of the elective waiting list, but actually there's been a structural challenge that's been going on for a long time. And as people live longer and they need more care, we need to think about different ways of solving that problem for them. If you look at the way that we currently go around patient engagement and the way that we offer digital tools to patients, to be honest, it's a mess. There's lots of different systems, they don't pull together and they don't help us move to a different way of delivering care. And our vision is a remote-first healthcare system, which solves that problem of supply and demand, but whilst actually improving quality rather than sacrificing it. And we do that by shifting to what we call a digital-first model. And a digital-first model is a world where instead of travelling into outpatients, and instead of having all of your appointments based on kind of time and place, everything is done online first of all, and we begin to see patients based on their need rather than just where they were in the queue. Specifically, what our product set does is it provides activation through the ability to self-book. We collect new data from patients in order to make informed clinical decisions. And wherever possible, as I said, interactions are delivered remotely by default. In practice, it looks a little bit like this. We call it the patient layer, and in the next 5 years, every single hospital in the NHS is going to invest in some sort of patient layer. If they're not doing it already, they will be very, very soon. And it's what I consider the third wave of digitisation in healthcare service. So we started by digitising our administration systems, our PASs. We then had a layer of clinical digitisation through the EPRs, so the Epics and the Cerners and pathology systems and everything like that. And the third wave of digitisation is this patient layer, which is all about looking outside of the organisation, integrating with the existing clinical systems, but looking outside of the organisation to do real-time communication with patients, to run automations, and then, as I said, to collect data from patients so that we can run new and intelligent workflows. And I'm really excited by what the future looks like, because a world where everything happens online by default, patients get the type of care when they need it in the way that they need it, is how we're going to solve the ongoing crisis that we're seeing in supply and demand driven by COVID. As a patient, it looks like the stuff you see on the right. So you get all your information online. There's a load of text messaging and email tools that come with this. And we essentially talk about 3 key products. So our engagement product, which is all about helping patients shift to digital. Our scheduling product, which is about reducing the admin overhead and making sure that clinics run effectively and efficiently. And our assessments product, which is all about collecting new data from patients so that we can measure outcomes and can feed that data back into scheduling decisions so we're seeing patients in the right order. Ultimately, this is all about helping the NHS to work better. Ever since we started this business, all the way back in 2012, that's been really core to everything we do. And I genuinely believe we are on this kind of moment of inflection in the way healthcare is delivered. And by leveraging platforms like ours and AI and all the technology that we're going to talk about and the other teams are going to talk about later, we can deliver a much more sustainable, much more patient-centric healthcare system. So without further ado, I'm going to hand over to Tom, who is going to talk about our journey through AI.
Brilliant. Hi everybody, so I am the other Tom from DrDoctor, and I am the product manager for the data pod here. We are the team that are responsible for actually building these products. So today I want to talk to you through our journey with AI at DrDoctor. So I want to tell you about how we identified the areas that we're going to apply AI to. I'm going to talk about the products that we're actually building and the problems that they're solving, and also then a little bit about the future of AI at DrDoctor. So, when we started this project, we realised that AI is a very versatile and broad topic, and there's a lot of different avenues we could go down to apply AI to our products and healthcare. But principally, we started by thinking about, well, what are the different projects we could do? And we looked at the 7 different patterns of AI. And these are the broad categories that most AI projects fall into today. There is hyper-personalisation, which is about developing a unique profile or view of an individual. There are recognition, such as image or video recognition and classification tools. There's conversation and human interaction, so chatbots, natural language processing, understanding the language that we speak as humans. There's predictive analytics and decision support, so taking historical data and using that to model and predict the future or guide decisions about the future. There are goal-driven systems, so systems that learn through trial and error and reinforcement learning. Autonomous systems, which is taking away manual, repetitive tasks of humans and using AI to automate those. And finally, patterns and anomaly detection, so finding patterns as well as the outliers and anomalous results within that data. So, as I said, we looked across the board and thought, well, there are lots of different opportunities we could explore with AI. But at a starting point, we realised that within our field and with our industry that we work within, pattern and anomaly detection and predictive analytics and decision support were the areas we wanted to explore. So, what are we actually building? Well, over the next 3 years, we're going to build 3 AI products, and we're going to do it in 3 phases. The first of those products is going to be a predictive model that is going to try and predict when patients are not going to attend their appointments, so a DNA prediction model and attendance optimization. Next, we're going down the pattern and anomaly detection route, trying to detect when appointments across multiple systems or pathways are actually linked together and the impact of cancelling those. And finally, we're going to provide an AI-assisted decision support tool to clinicians to decide on the best course of pathway for a patient or stratification. So, now talking those in a little bit more detail. So phase 1, our appointment optimization. Well, what's the problem we're trying to solve here? Well, it's well known that DNA rate, or do not attend, is a big issue for the NHS. The national average is over 10% for DNA rate. Every missed appointment costs between £90 and £140. And you add this all up across the board, it's almost a £1 billion problem for the NHS. So at that high level, it's a huge number. But even down to a trust level, it's still a multi-million-pound problem that each of our trusts are facing. But it's not an unknown issue. There's been a lot of research done into this before. So when we started out, our data science team formed a detailed literature review. We looked at over 10 scientific papers and studies, all about the different reasons why people have missed their appointments. And what we found out is that this is a real mixed bag. There are a lot of different inputs to that. For example, people forget about their appointment. There may be issues with transport, getting there and back. They may have personal health issues that make it limited for them to travel. Problems with work, problems with anticipating wait times, even down to the weather having an impact. So what we realised is there isn't a blanket catch-all answer to this. It's a complex problem with lots of complex interdependent variables. For example, we may know that on a Tuesday or a certain time of day, the DNA rate is higher, but that doesn't get into detail of why it's higher on that day. For example, somebody could be on a 0 hours work contract, and because their appointment is in the middle of the workday, they're weighing up getting paid versus going to see a doctor about the issue they have. Alternatively, somebody may live a long distance away from a hospital in a rural area where they have to rely on public transport, and due to the times of the buses and the traffic and the distance that they are, it's an extremely long journey, and they decided not to make that journey in, particularly in a COVID environment where travelling on public transport may be deemed a risk. So, considering all these factors, it is a complex challenge using lots of complex interdependent variables. But that is what makes it such a great candidate for AI and machine learning. So, what is it we're building? Phase 1, we are building a model that's going to bring together all these complex different inputs and predict the likelihood of a given patient or appointment DNAing. So, before I get into the benefits of it, I'm going to talk you through at a high level how we're actually going to build this thing and how it's going to work. For phase one, we're building a supervised machine learning model. And supervised machine learning is all about generating predictions from data with labels and features. What does that mean? Well, step one of that is about creating a labeled data set. We'll take historic appointments that we have about patients and appointments, and the historic outcome, whether they did attend or whether they DNA'd in the past. We'll then enrich that data set with features that we believe may have an impact on the likelihood of DNAing. For example, the time of day, the specialty, the number of previous DNAs, things like that we get from our existing DrDoctor products. We're also going to enrich that with external data sets. For example, the distance from the hospital, we can combine that with MAPS data and the address that we have for them, or the rural versus urban indicator, and many, many more fields. That really is open-ended view to the kind of data we can bring into this model. But once we have that enriched data set, step 3 is to split it into a training and a testing data set. We then take that training data set and we feed it into our algorithm and our model to identify patterns and relationships between all of those input features. So the way I like to think about this is the model is basically trying to find the optimal combination of metrics between all those different inputs. So it's saying a little bit of A plus a bit of B minus a bit of C. What is the optimal formula that's going to accurately predict the outcome every single time? So once we've been trained that model and it's found its optimal formula, what we do is we give it that test data set. So we give it, here's all that historic data, but we're not going to tell you what actually happened. Instead, we want you to predict it. At which point, the model will churn out a prediction value for each appointment as to how likely they think DNA is going to happen, and we'll compare it against the historic outcome of what actually did happen. At that point, we look at the level of accuracy of the model, and we may go back, reiterate, and define the model. For example, we may realise that hour of day doesn't have much of a big impact as we thought. We may try day of the week or a completely different variable. But we'll go through this process and refine the model until we're happy with the accuracy level. Finally, when we're happy with it, we deploy it to production and we start predicting real upcoming appointments. And the final point is that we continue to monitor the performance of the model, because we're very aware that those inputs will change over time. It's going to be really interesting to see in a pre- and post-COVID world how these different factors and independent variables change. So that's how we're building it, but how do we then apply this to solve real problems? Well, with the model in production, we then feed upcoming appointments for a trust. The model will then obviously generate predictions, as we hoped it would, and we then move into the phase of interventions. So within our DrDoctor products, with our booking teams and members of trusts, they will be able to see a list of all the upcoming appointments and the likelihood that that appointment is going to be missed or DNA'd. The first of these interventions is sending notifications. A trust member can send additional notifications to remind a patient of the appointment, or just send additional requests for help or anything else we deem as a good message to be sending that could impact DNA. But the second piece of this, which is interesting, is that we can actually, from some manual phone interventions, we can actually call up patients and go, hey, is there anything we could do to help with your appointment tomorrow? Ultimately, off the back of this, what we hope we will see is that as soon as we start having these interventions, we're going to be bringing down that DNA rate as we've been understanding why patients can't make it and holding these and getting more information about the challenges they face and why DNA rate has been higher. So how does this help? So, well, principally, by improving DNA rate by just 1%, that's going to result in £144 million of annual saving to the NHS. That alone is a monumental figure in itself. But there's other areas of this as well. By calling up and understanding and getting a richer data set as to why people are DNAing, we're going to start to identify unknown issues within communities as to why patients are actually DNAing. And this links into the third point, really around addressing health inequalities by using hyper-personalisation. So to take it back to some of those examples earlier, we know that every missed appointment costs up to £160. That person who lives far away and decided they aren't going to come in because of the public transport and the time is going to take them too long. There's a chance it actually is more potentially viable that we pay for a £5 or £10 taxi to get that person in within 15 minutes, rather than losing the £160 on that appointment and again on the subsequent appointment, as well as the potential impact that person has on their health by not being seen as soon as possible. These are just some of the initial areas that we realise and the benefits that are going to be come to fruition from this model. But as we continue to build and enrich with more and more data sets, the possibilities really are endless with DNA prediction. So, unfortunately I haven't got time to go through other projects in as much detail today, but I do want to give you a little quick preview of what Phase 2 and Phase 3 are about. So Phase 2 is our linked appointments project. This is using AI to address the issue when a patient pathway is split across multiple systems or booking teams. The challenge we have with this is that when a patient or booking team member comes in and cancels, say, appointment number 3, that the systems aren't set up in a way that realises that this is linked to other appointments and there may be dependencies. This in turn causes an issue with wasted appointments, which is another cumulative effect to the NHS and the backlog. What we want to do with a model is predict these linkages and understand where these correlations and linkages are so that we can prevent accidental cancellations, and also begin to model more complex pathways that we didn't realise that spun across multiple systems and multiple different specialties. So that's Phase 2. Our final product is AI Assisted Stratification. So as it stands today, DrDoctor have a forms or assessments product that enables clinicians to send forms before or after an appointment with a patient. They can then take this data and they can evaluate it and decide the best course of action. The challenge is, this involves a lot of cognitive load to review a large amount of information in a short period of time and make a decision. So what we want to do is feed the forms data in to a model, as well as all the historic decisions made by multiple clinicians. And we're ultimately building a wisdom of crowds model here. What the model will show now is it will give back the clinician all that forms data, but it will also give them an advisory that says, based on patients who answered the form in a similar way, this is the course of action that a bunch of previous clinicians decided was the best course of action. Whether that is moving someone to be seen more urgently, whether they needed a follow-up appointment, or whether they didn't. Ultimately, the goal of this is to provide AI-assisted decision support. The decision still sits with the clinician, but it's reducing that cognitive load to review a lot of information in a short period of time, harnessing the power of AI. So, those are the 3 projects we're working on today, but we really see that this is just the start for AI at DrDoctor. As I mentioned before, the 2 areas we've focused in on have been on patterns and anomalies and predictive analytics and decisions. But already within the team, we're noticing more and more opportunities within these where we could be using more AI in even more interesting areas. For example, we've thought about chatbots for rescheduling appointments and support there. We've thought about hyper-personalised messaging content when we send those notifications. So for example, we could realise one of the reasons that people don't attend their appointment is that their first spoken language isn't actually English. So instead, could we start sending those appointment reminders in their given language, much more likely to attend? When we start getting this real rich view of the challenges patients face, we can start using AI to provide much better care for them in the future. And that's really where we see AI headed within DrDoctor and within healthcare.